Good afternoon. Welcome to Doc Talk Live. I want to introduce you guys to John Kippenberger,
yes,
who's in from Atlanta today, and Sam Frazier, who's a patient of mine. And you realize this is live, we're on Facebook, so any information we release about you is personal, is you've given us permission. Is that
yes.
accurate to say?
Don't get too personal. I've known you for 10 years.
Okay.
Yeah.
So just don't answer any question that you feel is too personal, okay?
Okay.
So I'm just trying to think of how I want to structure this, okay? The reason John is here is John is a salesman, and in the life of a physician, we have what are called sales representatives or pharmaceutical representatives or various reps come in and try to give us information about particular technologies or products or drugs or pharmaceuticals or whatever it is. And frankly, I think of you guys like lobbyists, like to politicians. Like you're basically, your role is to educate the doctor, but primarily you're trying to sell a product. And I'm not saying that in a good way or a bad way. I just want to sort of be upfront with
Sure.
with who you are, and you are a salesman, okay? But the reason I want to do this show with you is, one, I want patients to sort of experience what the doctor experiences when he visits with a sales pharmaceutical representative. But plus, I think the information that you have to impart is very interesting and very interesting to my audience. Sam, I've asked you to be here because John is going to give me information, and I am going to quiz John. I am going to really push John in this information, but at the end of the day, it's got to be relatable to the public, and that's who's watching this. And so you are my audience, if you will. And I can't always get or elicit the questions because my show is not big enough, frankly. If I had 1 million viewers, we would have lots of people. You're my 1 million viewers, okay? So if I'm saying something that doesn't make sense, I want you to help me as a listener who has a vested interest in this topic, okay?
Sure.
So just to give you some information about Sam, Sam has chronic back pain.
Okay.
And what's interesting about Sam is that it's been a bit of a challenge to isolate Osama bin Laden. We know Osama is terrorizing his back, but we haven't been really very certain as to where he's hiding. Much like Osama, they thought he was in Afghanistan, or maybe Baghdad, and maybe here, and then they finally determined his exact location, which was in Pakistan, in a house. And so we went through, we looked at imaging. Imaging was like spy data, and when you look at Sam's imaging, he has just a hint that he's got some degeneration. This disc is a little bit darker than the other discs above and below it. It was a little hint that, maybe Osama bin Laden is hiding there, okay? Now, what we did is we sent in SEAL Team 6 to that address, and he's had missions run on his back before, which were maybe only mildly successful. They helped temporarily, okay? But we ran a new mission on his back, and we put in medicine right into that disc, and he did better with that than he has with other missions, okay? Suggesting, not beyond a shadow of a doubt, but suggesting to a reasonable degree of certainty that indeed is the source of his symptomatology in his back. So we've learned two things about Sam recently. One is that disc only looks a little bit bad, but it seems to be feeling awful, okay? And we have, in a way, we've kind of proven that that's where Osama is, okay? Sam is like, well, what do we do next, Doc? And I'm like, well, right now we do nothing. If you're doing better, we just sort of wait and see, okay? But what I've done is not a cure. I've put steroids in there.
Yeah.
I've put anti-inflammatory in there, and I know that that's not a long-term solution. It's a short-term. Now, long-term, his body might just take care of the problem, which would be great. His own healing mechanisms may take care of the problem. But he said to me in the office today, he says, well, what do we do next? And I said, oh, well, good. I'm glad John's going to be here. And we're going to talk about next, okay? So, John, I've talked enough. I don't have any water. Blake, you're supposed to have water. No, I'm kidding. Talk long. Tell our listeners who you are, okay, and what your role may be in this situation.
Sure, yeah, absolutely. So I work for, as Dr. Goodman mentioned, I work in a sales, marketing, management role for Catalyst Regenerative. We're a company that is 100% focused in regenerative medicine, and what that means to the lay public is that we utilize therapies that either are sourced from the patient's own body or they're sourced externally, but they're all natural therapies that can promote healing or potential regeneration depending on what the clinical situation or what the injury or the chronic clinical condition may be. And so we have a number of different therapies in our offering that the company has, and Dr. Goodman and I were recently talking about a couple of those, and certainly I can expound on.
Well, now what I want you to do is I want you to sell me.
Okay.
I want you to stop talking to them.
Sure.
And pretend like you've come in, and I want you to sell me. And then while you sell me, I'm going to try to make it so the public can understand it.
Okay, fair enough. So if we take Sam's condition of his what appears to be a chronic, is it all axial or lower back pain, Sam, or is there any?
It refers into the left leg, I believe.
Yeah, there's
It's
no.
more the left buttock, right?
Yeah, buttock to hip area moves around, but there's no actual back pain.
So it's a referred pain that we believe Osama is living in that disc.
Okay.
And we put medicine in there, and it's suggestive that that disc is leaky, that there's a tear in it.
Sure. Yeah.
The tear is probably in the annulus out here in the periphery of the disc, and it's leaking evil humors into around the nerves that go down his leg, sort of inflammatory in nature.
Okay.
But it's not bad enough. He's had surgery before to remove a ruptured disc there, correct?
Just to scare you here.
Bulging disc.
But you've had surgery on it, right?
Oh, yes.
He's had surgery, but there's nothing surgical now. It's not protruding. I believe the disc just seems to be leaky.
Okay. Fair enough. So I think
So if we could heal, if we could regenerate the nucleus, and if we could heal the tears in the annulus, that would be a truly regenerative therapy. And in that space of regeneration, you've got trials that are going on that we currently do. We work with a company called Mesoblast, which makes a stem cell to regenerate the disc. There's a company called Discgenics, who one of my partners works with, to put in discogenic stem cells to regenerate the disc. But those therapies are not readily available. But certainly you could look at your type of therapies, which are readily available. So what can you do for me to help?
They
Sam?
are. So there's really a few different options that are out there that can be offered.
Okay.
So one would be
and I assume that these options would translate to the patient who had arthritis in their knee. Is that correct?
Sure. Yeah. They could.
So
yeah,
I don't want us to get focused on the back to our listeners.
Yeah.
I want them to think about this as arthritis in any joint.
Right. So like I said, so there's a few different options that providers can offer to their patients. Okay, one of those would be a therapy that is focused what they call protease inhibition. Okay, what that means for the lay public is in a degenerative situation, whether that be a joint, knee, hip, shoulder, also could be a disc. What we know from scientific research is that there is a lot of what they call proteolytic enzymes. We'll call those bad enzymes.
Okay.
They continue to attack the healthy tissue and cartilage. I'll give you an example. That's why when you hear about an osteoarthritic joint, there's grades to that. The lesser the damaged area, they start at a grade 1. When you progress all the way to a grade 4, typically you have a bone-on-bone situation. You become a candidate for a joint replacement procedure. Okay, and the reason that those continue to go from grade 1 to 4 is because those enzymes, those bad enzymes, continually are attacking the healthy tissue and cartilage. Okay, so there's a therapy out there. I mentioned protease inhibition, meaning we're going to stop that enzyme activity. Okay, it's called, there's a molecule that is found in all of our blood. It's called alpha-2 macroglobulin. It essentially is the body's natural response to inflammation.
Okay.
Okay?
And we'll shorten that. We'll call it A2M.
We're going to call it A2M for short.
Okay.
Okay. And the way that the therapy works is blood is drawn from the patient. It then is processed in a centrifuge. So in essence, it is spun down, and then there is plasma that is going to be separated from the blood. The plasma is key because that is where the A2M primarily resides, okay? And then we're going to take that another step further, and we're going to use a separate piece of equipment that is going to isolate and concentrate that alpha-2 macroglobulin molecule. Now, this is important to note. That molecule is a large molecule in comparison to other molecules that you will find within the body. That is why, let's take a osteoarthritic knee. So if you would go in and you would look microscopically in a osteoarthritic knee, you would maybe only find trace amounts of the alpha-2 macroglobulin molecule. Okay? That would not be sufficient enough to have a therapeutic benefit to counter the bad enzyme activity that's taking place. So the reason we're doing this processing is what the research, if you go back, and it's 15 years ago, they discovered that if you can bring the A2M molecule in a high dose, high concentrated level, it works as a what they call a master protease inhibitor, meaning it will essentially bait and trap all the negative enzyme activity, and essentially what it does, it halts the progression of the disease state, of the degeneration. Okay?
This is similar to PRP, correct? It's a different molecule, but it's
only similar from a initial processing standpoint, but the mechanism of action from a therapeutic standpoint is quite different. PRP is founded based on growth factors. It's a growth factor therapy, okay? And growth factors can have a part in the equation, but right now when you have a significant degenerative condition going on, you can think of it this way. We're going to use A2M to biologically clean out that joint, or you could biologically impact the enzyme activity within the disc, okay?
So just to back up, PRP is a regenerative therapy which involves similar steps. You draw a patient's blood, you get the blood, you spin it, and you get the layers of blood, and one of those layers is the platelet-rich plasma. and you take that platelet-rich plasma, you put it in the knee, and you use that to stimulate healing. This product that John is selling takes what's called the platelet-poor plasma.
Which is what we kind of put.
We put them together. But he takes the platelet-poor plasma and he isolates the A2M molecule. And he uses that A2M molecule, if I understand you right, to basically be like a natural biologic steroid to halt the progression of inflammatory damage to the structure. He would then go in, I would say maybe 6 weeks later, in an ideal situation, once he's sort of cleaned out the environment, he would then go in with maybe a stem cell product or a PRP product.
You could do a growth factor or a stem cell therapy.
To then cause, it would be in the ideal scenario,
right.
that would be the way you would attack it. You'd clean out the joint first, and then 2 months later you go in with a stem cell or growth factor to try to cause regeneration.
That would be the ideal protocol.
Now before I start stabbing holes in this whole thing, I want to get at the test you have, which I think is important. Tell us about the fibronectin component of this whole thing, so they know.
Real quick, I've got a question that's popped up, I think, before we move on to the next.
Okay.
Will my insurance pay for that?
No, absolutely not.
Sorry, Mimi.
And the reason insurance doesn't pay for it, well, I shouldn't speak for the insurance company, but my guess is that a lot of these therapies are unproven, and so these therapies do not meet the mustard of what insurance companies will generally pay for, because they're not, although they may be FDA approved, they haven't been shown to be effective, because the studies in humans have not been done.
Correct.
So generally speaking, these are not paid for by insurance, which we're going to get to shortly. I'm going to get to that piece of the puzzle. So there's a test, though, that I want you to get at.
Yes,
it's important.
Right. Yeah, and it's very dynamic in the field of regenerative medicine that the A2M therapy is the only therapy or the only offering where there is a true diagnostic test that you can utilize to see if you would even be a candidate who would be a responder to the therapy. Okay, and the way it works is, first, just from a scientific standpoint, there's what they refer to as a known biomarker of cartilage breakdown, and it's something called fibronectin aggregate complex. We call it FAC for short. Okay, and the way that it's tested and measured is that either the physician can take a small sample of synovial fluid, which sometimes is attainable, typically in the knee, or if there's other joints that are involved, in lieu of synovial fluid, the physician will inject a small amount of sterile saline, and essentially what that does is we're going to use that to wash the joint, and then we bring a small amount, we're talking about a little over of 1/3 of a cc, so it's a very small amount, and that gets sent off to a lab, and they come back with a report, and what they're looking for is a minimal quantifiable level of this FAC complex. If that is at that minimal level or above, it tells the physician provider and the patient that there is significant cartilage tissue breakdown activity that's being caused by those bad enzymes, okay? And it lets the patient know that they would be a good responder to the A2M therapy. Now, what we've seen, and this is from all the utilization, and this is anecdotal, but There is,
anecdotal means the worst type of evidence
right.
there is, but it's still evidence. Okay, it's just the lowest form of evidence.
But in the and I don't have the exact number, but there's been thousands of patients utilizing the A2M therapy. If you are a responder to the diagnostic, typically 90% or more of those patients are going to have a positive response or outcome.
So let me speak to you, Blake, before you say something, because I want to tell Blake why this is important. Is in general, this A2M device, this A2M isolator, John would charge me for this kit $1,500. So because this kit is so expensive, my minimum cost of this is $1,500, they at least have a test, which is free, that would determine in advance whether the patient should respond to their own A2M. So that's why we're going into this. Now, in general, PRP, my cost when we stock the product, get it in, distribute it, is about $450. So most patients just say, hey, I'll buy the kit, but $1,500 is 3 times that cost. And so how do you decide whether or not to utilize the A2M? Well, they've got to test. The problem with the test is I've got to go in and I've got to get fluid out of the joint or lavage it with intervention in order to determine whether it will work.
Yeah, that was going to be my question. If you're a patient, okay, what do you have to do to get to that step? Is it something under sedation? Are you...
Well, so in your case, since we're looking at disc...
That was going to be my question. If it's a spine, do we take disc material?
Well, we would have to lavage that disc. Theoretically, the next time we would go in there, if we were to go in there at all, but let's say a year from now, your symptoms were to return, and you said these are the exact same symptoms. We had a new MRI. Things are pretty stable. There's nothing surgical going on, and you say, golly, that shot you gave me with steroids a year ago was the best thing ever. I'm interested in repeating it. Well, while we were there, we would probably go in and try to lavage it, i.e. put a little water in there and suck that water back out, and send it off to the lab to see whether this FAC compound was there. Meanwhile, we would still put the medicine in there and hope for the best. But then we might have an answer at that time that FAC is there and that you would respond to your own A2M. But then you would have to be paying $1,500 plus all the additional costs that would go with an A2M injection, X-ray, anesthesia, tray, things like that. So you're looking at a $3,000 cost minimum just to provide a therapy to the disc like that, which is why the knee is so much easier. The knee is a lot easier because we don't have to go into an OR suite with an X-ray. Right in the office, you can, but the knee would be treated the same way as the back. It would be like, okay, let's get a little fluid, let's see if the A2M is there, and then so this really brings up my dilemma, which is from a regenerative therapy, how do you come up with I always forget this word, this like flow diagram of how you decide where this treatment fits?
Algorithm.
Algorithm. That's the word I always forget. Sure. Algorithm. Where in the algorithm, is A2M? And I know you would say, because you're the salesman, it's got to be right at the top of the algorithm. But the problem is there are a whole host, John, of regenerative therapies out there, from taking fat or bone marrow and isolating stem cells, to taking blood and getting PRP, to amniotic fluid, to A2M. And so this is where I struggle.
Sure.
How does the patient and physician, how do they decide, how to proceed? You follow me?
I do.
Help me with that.
Yeah, and because
and I don't mind if you put your salesman hat on here.
No,
I don't mind.
No, we have all of those therapies in our portfolio.
Mm-hmm.
Okay, and really back to one of your original points. Part of my role is to educate. Okay, and provide educational, factual information related to all the different therapies, and then really come across as somewhat as therapy agnostic in terms of what the physician or provider is going to use, and that should be based on maybe what they see as most applicable for each specific patient.
Yeah,
now,
but here, as the provider,
right,
I have no data.
Right.
I have no data at all from which to go from. What I have is this sales guy and that sales guy and that sales guy, all with information that says my product is the best, but no data to support that claim, in my opinion.
No, that's fair. I mean, that's because we're very early on within the regenerative medicine landscape or market right now. We are somewhat reliant on the providers. The science is there, right? The science is there to validate these therapies.
Yes, the basic science is there. I agree
the level
with you.
1 published data, that's what the insurance companies are interested in. That is not there. And one of the main reasons that is not there is because the majority of the research and the studies are borne out from very small, lab entities or smaller research companies.
Well, the level 1 data is not there specifically because it costs $100 million
that's where I was going.
to get that data.
Right. So,
And when you think about investing $100 million on a product that sells for $1,500,
right.
it's hard to make that.
Yeah, absolutely.
So apparently there's enough patients out there who come with their own product. I mean, the product is in their bodies.
Right, exactly.
They're walking around with it.
Right. Yeah.
And it's in their wallet.
Right.
So the companies aren't really incentivized right now to get the good data.
Exactly. Yeah. Just it's truly cost prohibitive. So we're back to we're relying on the physicians and the providers to apply, their critical thinking skills to translate or transition the science to clinical application. And I know when you're looking at those host of choices, that can be a little challenging. It can be confusing.
Well,
so
let's say this. Let's take Sam's problem and take it from his back into his knee.
Okay.
Let's say the problem's in his knee, but it's the same problem. And so Sam's at a crossroads. He doesn't need knee replacement surgery. Okay. He doesn't need arthroscopy anymore. Let's say he's had it. He's had a minimal cartilage repair arthroscopically.
Sure.
He gets a cortisone injection in his knee, and he gets 6 weeks of phenomenal relief, but then he's miserable the rest of the year. Okay? So he is basically left with living with the problem or trying a regenerative therapy. Mm-hmm. And we're going to say that he's doing physical therapy, he's tried bracing, he's tried other things, okay?
Right.
So from a regenerative therapy, my bias would be really the PRP, PPP mixture. In that regard, it's relatively cheap. It costs him $450. He gets the growth factors,
right,
and he gets the A2M because it's in the PPP. He gets the whole gamish.
And what's the difference?
So
the difference is, this is what John would say. John would say that for $450 you get all that, but for $1,500 you get this concentrated product called A2M, and it's concentrated by what he does. It's not in low concentrations by the PRP, PPP thing, and it basically halts to a better extent. This would be the sales job here. To a better extent, it halts this degradative process that's going on inside your knee, assuming you have this fibronectin,
the FAC.
The FAC, this complex of
validating.
Right, assuming that you've got your FAC positive, the A2M would halt this degradative process, and then he would say you come back for that other $500 about 2 months later and get the PRP.
Possibly. There's a lot of patients that have just standalone A2M treatments and have done extremely well, and it varies.
But there's a lot of patients that have PRP and PPP and have done very well.
Absolutely, and then again, so I think every provider, kind of based on, again, their understanding of the therapies, what they're working with and dealing with in their practice, they're going to set their own algorithms, if you will, and follow those. So what you're telling me, and what I'm hearing, if I'm hearing this correctly, is you would start first and make that offering of PRP, PPP,
because it's cheaper
formulation, right? And you're going to start there, and that's fine. That's
so a
fine.
Physician that would start with A2M would be doing it based on the fact that they have seen stronger results.
Absolutely, they just have experience. They and I know some of those physicians.
I'm sure you do. I'm sure you do.
They just for that intra-articular application, they've just seen very mixed results, and based on that, that has led them to, they could possibly still offer that, but if they're going to give from their personal experience, they'll make the suggestion that, maybe
now a lot of times patients are well read. In other words, they have become very proactive in terms of regenerative therapies.
Sure.
And basically the sort of the hierarchy, or I think of it as a triangle. There's like 3 types of regenerative therapies. There is stem cells, okay, which are like seeds. There is growth factors, which is like fertilizers. And there are scaffolds, which is like soil. So there's these 3 types of regenerative therapy: seeds, fertilizers, and scaffolds. Seeds are stem cells. Okay. Fertilizers are like growth factors. That would be your PRP, your amniotic fluid tissues, things like that. Sure. And then soils or scaffolds would be like the PPP, the platelet poor plasma, or the Synvisc or hyaluronic acid type injections. They would be like scaffolds that would just basically be sticky stuff for all this stuff to glob onto.
Okay.
Where would A2M fit in that triangle?
So A2M is unique in its own category, if you will.
Yeah, it's like a 4th category.
Protease inhibition. Okay.
Okay.
So there's only 2 protease inhibition therapies that are on the market. Okay. Alpha-2 macroglobulinate A2M, or something called IRAP. Now, IRAP targets a specific molecule, okay, interleukin 10, which is a strong, inflammatory,
pro-inflammatory cytokine or protein.
Exactly.
Okay. Are there biomarkers for that, like FAC, that you can get routinely?
Not that I'm aware of. And in the U.S., IRAP is only approved to be utilized in the equine space. So
in the horses.
In Europe, you can go over and have that done. However, one would counter that while it's potent and powerful for that one specific enzyme, what about all the others? And that's where really the benefit of A2M comes from. It is a master protease inhibitor, so it blocks all the enzyme activity that's occurring there.
So this this is a really good question.
Mine aren't good.
Well, they are, but this kind of goes, along with $1,500. Okay, that's a lot of money. So the question
that's just my cost. By the way, I could charge $50,000 or I could charge $1,501. That's just my cost to get it.
So the question is, how long does it help? How often is it needed?
Great
It
question.
varies patient to patient. She says she knows that, but you're forking out a lot of money. How long is this going to buy me?
So on average, we'll see patients benefit for a year plus. Okay, some patients will have been out, 2+ years, even into the 3rd year. Again, that is going to be factored into where they are in the disease continuum, if you will. What does their activities of daily living look like? So are we talking about an individual who's maybe younger, middle age, very athletic, who's out there, whatever, whether it's tennis, running,
So their
jogging.
goals play a lot into it.
Right. Or is it that grandmother who simply, her objective is to get out of pain and get up and down the steps easier, and maybe be able to bend down and play with the grandkids some. So so it's going to really vary from that perspective. But on average, typically we'll see at least a year, and then it can go beyond that. So some patients do come back in at a point where symptoms now start to present again significantly. Pain is returning, activities are being inhibited, and they'll come back in and potentially repeat that.
My point was, John, is that sometimes patients drive the care because I can't really say one product is better than another. And so some patients will say, hey, I'm really interested in A2M, or I'm really interested in PRP,
Absolutely.
or I'm really interested in stem cells. They might say, what do you think? But they might have a very strong bias going
Sure.
on. What are some resources that you're aware of, other than Google search stem cells or regenerative medicine? Are there any resources that come to mind?
Good question. I mean, there's a lot of different things out there, obviously.
What about your website? Why
Absolutely.
not promote your website?
Well, sure,
Do you
yeah.
have a website?
We do, yeah.
What is it?
CatalystPRN.com.
Catalyst PRN.
PRN.com.
What's PRN?
It stands for Physicians Resource Network.
Okay.
Okay, and that's part of when we start to work with our physicians, we have a resource network that we're building, because that's one of the things that we want to do is we want to have shared communication between our practices, so we can help drive really better treatment protocols, more predictable treatment protocols for patients. Because you said it earlier, Dr. Min, you're right. Right now in regenerative medicine, I mean, I have what I think would be 3 outstanding therapies to help Sam, but I can't tell you definitively, because I don't have data yet that says one is going to be better than the other. Okay?
What are your 3 outstanding therapies?
So
That's one, yeah.
or actually, I'll come up with 4.
All right, give me your 4
so
therapies.
A2M would be one.
Okay.
Okay.
$1,500 for the product. Next.
Correct. Autologous bone marrow aspirate stem cells would be another.
Okay, what is that? What is the kit cost for that?
$1,250.
Okay. Next.
Next is 100% pure amniotic fluid.
Which costs what? For, let's say, 2 cc's.
2 cc's, $1,400.
Okay, so those are one and the same in cost. So everything's about the same so far.
And then the last one is really the latest advancement in all of regenerative medicine, and particularly in stem cell therapy. It's a stem cell derived therapy called exosomes. Okay.
Oh, we have a whole new topic to talk about now. Exosomes.
Okay.
Let me just review again.
Sure.
You mentioned A2M. You mentioned bone marrow aspirate, which is stem cells. You mentioned amniotic fluid.
Pure
Okay.
amniotic fluid.
So all of those are around $1,500, right?
Mm-hmm.
cost, and then exosomes. All right. Tell us briefly about exosomes.
Okay. Before we do,
Sure.
Okay, yeah.
I've got a question.
All right.
These questions. This is probably for you. If people use this regenerative protocol, do I have to stop having blocks? Pain blocks are paid for by the insurance, by the way.
Well, the goal of any treatment is to halt all treatments. So the less pain blocks that I do for you, the better job I've done. Okay? So it doesn't necessarily halt having blocks, but that would be a biomarker, if you will, for a failed therapy. I'm not saying the therapy failed. I would just say that would suggest that you really haven't accomplished 100% of what you're trying to accomplish.
Yeah, I would agree with that.
And I guess that's given that you have just one pathological disc also. I mean,
There may be multiple pathologies, that's true, and you're only treating the one pathology. You could be getting a block for a different pathology. That's correct. That's correct. So what are exosomes? Now you've perked my interest. Now I'm really percolating here.
So exosomes are...
They sure sound cool.
They are. They're... Okay, we've talked a little bit about, we're going to dive a little bit into stem cell therapy. Okay, so and when we talk about stem cell therapy, we're talking about MSCs, or what's referred to as mesenchymal stem cells.
You know, before you go, if you could take a shot of my poster over there, Blake. Okay, so what you're looking at there are stem cells. And basically that one stem cell in the middle, that pluripotent stem cell, can become anything. All right? But there are other stem cells, and the mesenchymal stem cell, Blake, is right here. Here's the mesenchymal stem cell. So this is the stem cell that we use, let's say, in the disc. Okay? So that's just a pretty cool poster, so I like to put that up there. Okay. Sorry, Blake. All right. So exosomes, what were you saying?
So the key behind stem cell therapy is cell-to-cell communication. Okay, that's how the therapeutic effect of stem cells is going to shape and help and create a regenerative event or environment. Okay, how that happens is the communicators in that process are these tiny little extra cellular vesicles called exosomes. So they lie within the mesenchymal stem cell, and the mesenchymal stem cells release these exosomes, and that is what translates to the adjacent cells or tissue. The exosomes carry the important cargo or information that's going to create the regenerative event. They are highly rich in growth factors, more so than any other growth factor source that you're going to find in the body. Okay.
And so you've isolated these from what tissue? From where did you get your exosomes from?
So the exosomes are derived from a...
Hold on a second. What's going on, Blake?
It's just keeps disconnecting from the. You can keep going up.
Okay.
We're connected. It's just for some reason it keeps disconnected from the gimbal. I don't know why.
So
Is it maybe the gimbal's out of batteries?
No, it's lit up.
Maybe it needs an exosome.
Well, give me $1,500. We'll shoot it up.
you can turn it into a new gimbal.
Oh, goodness.
Do you want to take it off the gimbal?
No, we're good. I'm just going to reconnect it.
Yeah.
So.
Okay.
Yeah. So the exosomes are sourced from neonatal placental-derived MSCs or stem cells. Okay. So similar to an amniotic product, you have a full-term C-section consenting mother who donates those birth tissues. Okay.
Okay.
All right.
How much are the exosomes?
They're in the same ballpark as the other
Everything you
products.
have is $1,500. Don't you have any PRP?
Sure. We
But
actually
you
have
wouldn't advocate that. You said 4 therapies. You didn't even give me the PRP as a 5th one.
from an intra, well, for we're talking about Sam, and so based on that, that's just from my personal experience.
Okay.
I haven't seen that to be very effective.
Okay. But there is data at least on that. There is published studies on PRP.
So there's no connection.
There is, but it's
No
mixed.
connection between
Go
what?
ahead, Sam.
Well, no, I was going to say what you were describing earlier to me sounded as I would translate it into like a multivitamin, and it's got a lot of different things from all over. So from a layman's point of view, I would think, okay, give me the multivitamin. If I get anything from it, then that tells me maybe I can go a little further in one direction with something that's more targeted.
That's a great question. That's a great question.
Is there any correlation between these things? Because my first thought would be, I would rather do that and see how that goes, and if there's something there, especially again if there's a correlation, that's $500 as opposed to some very targeted things that are $1,500 a pop.
Sure, yeah, and that's perfectly fine. I mean, right? Again, if you're looking at it from a algorithm that's based on, and cost is going to be a factor. I mean, we realize that. Then, yeah, start. I guess with the most conservative, offering that you have, which is going to be the least expensive.
But is there any kind of correlation that you've seen so far? Is there any that helped a little bit, but I could be better?
We've seen either or. We've seen completely non-responders, and then they move on to what you would call a more advanced therapy, and then respond. Or we've seen, partial responders. So maybe you get relief for 90 days, 4 months, and then.
I must say that I like that multivitamin analogy.
Yeah, no, it's good.
And to me, the multivitamin of all the choices I heard would be the autologous stem cells, where you take the bone marrow and you get your own stem cells, and you could use PRP with that, and basically you're putting in a multivitamin, a lot of everything. But if you think about it, I mean, in regenerative therapies, we're basically either putting in the seeds, we're putting in the soil, or putting in the fertilizers, or dumping them all together, and then just hope that they know how to organize themselves and go to work. Whereas the exosome is interesting. You're like adding a little piece of basically a crewman in there.
Well, the exosomes
to
are,
help
yeah,
the communication between
exosomes
all
are
these
dynamic
things.
because they have the greatest resource of growth factors, but then there's also messenger RNA and microRNA, which basically is, if you think about from a layperson's perspective, it is the blueprint to deliver via the communication. So when you showed that before, and that mesenchymal stem cell has the ability to differentiate into bone, muscle, tissue, the reason it knows how to do that is
because of the environment it's in.
Well, it's the environment it's in, but it's the exosomes that go to that tissue that essentially what we call upregulate those cells or tissues, and essentially program them to become what they're intended to become.
Getting back to Sam for a moment. Sam, the real problem is there are a lot of options out there without any data at all to decipher what the best path is. And that makes it very, very challenging.
Well, and also if you're a patient, we're talking earlier about how to do research. Well, that's a really tricky thing to do, because most of the things you see out there are you don't know what the source is, and there's a fountain of misinformation. And
absolutely,
when you're dealing with something, especially when
which is why I tried to be transparent here from the very beginning, to say, hey, this guy's a salesman, he is a lobbyist, be careful. He just has a story to tell. You know what I'm saying? Not that I think, not that I I just want people to realize, I want people to consider the source. And that's what you're saying. You're saying patients don't have the resources to really parse through some of the information to know what's the best. Well, I'm going to tell you something. Us doctors don't necessarily have it either. We are lacking in this level 1 data. And one of the reasons we're lacking in it is that it's $100 million to procure. And no one wants to invest that.
Sure.
And so oftentimes in my regenerative practice, it becomes anecdotal. Like I say, Sam, hey, this is my experience. This is what I would do if I were you. But that's, you know,
well, I think
not
the other thing we see, and again, it's anecdotal, but there's a lot of patient testimonials out there, and so that's kind of how this shared information can start, where, you know, somebody's, you know,
but we can
family
find
member,
patient
friend,
testimonials for any of these therapies.
You can
And
find
so
patient testimonials for hair loss things, which are total gimmicks. It's very hard to sort through.
How much is placebo and how much is you know,
Right,
what's real?
right. But every product has testimonials. So
No, I'm just saying.
that's
though,
why
that's,
it becomes.
That's where, but I
It's not
mean,
nothing,
that's where when you look at options, and like I said, I think that they're like for your, you know, clinical condition, Sam, I mentioned the 4 that I thought would be very viable. But when you're looking and you're starting, whether it's a disc or it's a joint, you know, a knee, hip, shoulder, one of the best places at least to start is do that FAC test, because at least then you know initially what the problem is. Is there truly an intra-articular degenerative problem where there's cartilage breakdown?
Yeah, that is nice about the
if
A2M.
there
You can
is-
test whether or not you'll know the negative too, that hey, this isn't going to work because FAC is not there.
Right, or
That's the free one. That's the free part of it.
Well, relatively free. If you're buying the A2M, and it's as I understand
Sure.
it, let's say you came to me with a knee problem, and we were going to do a $1,500 A2M thing. We would get the FAC, and if the FAC came back negative, then he wouldn't get the A2M.
right, we would rule that therapy out because
But what if it were positive? Then he would
If it
be
was positive?
obligated to get it.
no, not at all.
Okay,
He
so
would
that's
be a
relatively
candidate.
free.
No.
You're basically offer that test for free.
Right. So optimally, the way it works, and what most providers do is this. You know, for the patients, again, for the routine joints, maybe not the disc, but you know, there's more viscosupplementation. You know, steroid injections when that patient comes in at that time. Before the medicine is injected, the needle's in place. So we'll do either the draw of the synovial fluid or the sterile saline lavage. Get the test sample, and then the next time the patient comes in, they'll have a report on this is what we're looking at.
But and wherever you're pulling this from, I take it that test is only effective for the one of the 4 that you were I forget, it's the A whatever, as opposed to the other 3.
Yes, A2M. It's
Okay,
only looking
A2M.
at the A2M treatment,
It's
the FAC.
it's looking
That
to
won't
see
help
if
you.
I mean, well, it's a good question. So it doesn't necessarily rule out the other therapies being used.
It would
because-
rule out the A2M if
Right.
it's
Oh,
not there.
if it's negative, absolutely. Yeah,
Yeah,
we
well,
would not.
But
want
it
to-
doesn't rule out the other therapies.
Right.
And there are there any tests for the other therapies
No.
that might say this might be effective
No.
or not? Okay.
No.
So that's why my point is that, again, we understand the commitment financially that the patient has with this. For them to make that, though, to have at least a diagnostic that says, okay, yes, I am, you know, a potential candidate for this, certainly can help in the equation.
Have you seen the FAC test go from positive to negative after the A2M?
Great question. Haven't really had any providers go back in and test.
and retest.
while the patient is asymptomatic. Now, like I said, patients could come back in 2 years later, year and a half later, whatever that is, and like, hey, I'm starting to hurt again, and I mean, there's a patient that I was aware of, younger, early 50s, healthy runner, not a very good knee. I'd say it would be kind to say it was probably a grade 3, but it wasn't bone on bone. Had a first A2M injection, did phenomenally well, significant relief, improved, back to normal activities for 14 months. And then things started to progress and worsen again, and he came back and got another A2M injection. And his
Again, to get back to you, Sam, and what I told you in the office is based on the SPY data and the missions that we've run by other doctors and myself. It looks like that this leaky disc is your particular issue.
Which for me is fantastic because that heals. Yeah.
It has the potential of healing, but there is no good treatment for it. There are just lots of bad ones. And he named, was it 4 or 5? I lost count.
4.
He named 4 bad ones. Okay? But they're all bad. Okay? And the reason they're all bad is because there's no proof that any of them work. But there's some treatments that are more bad than others. Okay? A more bad treatment would be like a fusion. Or a disc replacement. That's a big operation. But it's a treatment for a discogenic problem. Okay?
Okay.
So they're all bad.
That would be pretty criminal for a doctor to.
No, it wouldn't be. They'd be. If we've isolated that disc as the problem, if you take it out and fuse it, it should cure your problem.
Okay.
Okay, but then it's just a matter of time before the disc above it and below it would start to wear out.
Right.
I'm not saying all the treatments are bad, and if you've exhausted all the bad treatments, or you can't afford the bad treatments, and there's another bad treatment that insurance might pay for, okay, that just happens. They're all bad.
Well,
do you understand what I'm saying?
Sure. And my question would be, since you have to go potentially, let's just say you try one, it doesn't work, you try another, it doesn't work, and you're going down the line of these. The first thing is, when will you know if something is effective, and are there any risks in these?
You will know it's effective if you're playing tennis.
Oh, I just meant in general, anybody, and like how long does it take for this to kick in, and
I would say 6 weeks to 3 months is a good sort of time period when you're looking at regenerative therapies.
Okay.
Some from what I've seen and from what we've seen, some of the therapies that are stronger from an anti-inflammatory perspective
will work quicker.
That would be A2M. That would be a pure amniotic fluid. Some patients will respond, start to have a positive response even within maybe the first few days. I mean, it's gonna vary. But to Dr. Goodman's point, you're going to see a progression, and yes, I would think at least you'd want to say 6 weeks before, hey, this
minimum
is
6 weeks
not
before
effective.
Right.
Sure.
You want to give it a good 6
Absolutely.
weeks. But when you just think about in life, if you have a house that you want to tear down, you can literally destroy a house, tear it down, clean the land off in a couple days. But to rebuild the house takes months, maybe even a year. So it's the same thing. Therapies that destroy things, like if you remove a ruptured disc from the back, you should see immediate relief. You've taken out that ruptured disc, you've taken the pressure, boom. But if you want to regenerate a tissue, you have to give that a lot of time for it to happen. Much like if you were to build a house. You're not going to build a house in a week.
Sure. But getting back to the issue of say, risks, which I think a lot of patients would want to know, I mean, how does that compare with, say, having cortisone shots? Because people do know, cortisone shots are okay, but you really don't want to do that too often. And what are the risks of having this therapy?
very little risk with these therapies, if any. So these therapies burn no bridges. The biggest risk is to your wallet. That would be my opinion. I mean, I wouldn't say there's an additional risk to a steroid shot. And you bring out the point that steroids can be bad, and you're right. I mean, they can cause harm. But generally speaking, we see problems with steroids when people are taking them in large doses by mouth over a sustained period of time. It's not to say you can't have a problem with an injection, but you would have to have a lot of injections, which would be, more than, it would just be a large amount, more than I can even put a number on.
Sure. Well, I guess what I'm trying to do is come up with an argument, I suppose like you began with. Why would you choose to have this therapy over other therapies, especially given that it is not covered? So
other therapies aren't working. That would be one reason.
Of course, sure.
And for whatever reason, you believe that there is a reasonable chance of success given the investment that you're making, the financial investment that you're making.
You don't want to have a big spine fusion.
No one wants that. But that is an option. That is another bad treatment, just like all the other bad treatments. But some are more bad than others.
Well, and say if you have a knee, can this potentially save you from having to get a knee replacement?
Potentially. That would be the concept. Or push it down the line. Any more questions out there, Blake?
No.
Good. Sam, have we covered it all, or are you gonna hit us for more questions when we turn it off?
Oh, I don't know. I did make a list. Let's see. Before I came in here. When do you? Well, I guess that's a big thing is knowing when it's going to work and how long. You certainly wouldn't want to overlap, but at one point you just say, well, that one didn't work, now I'm ready to try the next one. So, when would you advise this sort of thing? Especially if you're going to run the gauntlet and say, well, I'm prepared to try all 4 of these because I really don't want to have to, say, have a fusion or a knee replacement.
It's a hard question.
That is a hard question.
I think some patients actually get fatigued. They just get tired of these therapies. And again, that's where the absence of data is really a detriment to this space.
And there's no way, because you're dealing with basically isolated doctors with their own experiences with it, and from a patient's perspective, well, you see one doctor and say, well, this one has worked well for me and my patients. You see somebody else and they'll say the exact opposite. There's no real outlet because there's not a centralized data gathering point. And
not at this point. Not at this point. We have, we have one published A2M study for degenerative disc. Small patient sample, 25 patients, but it was a good study and showed very good results. But that's one. It's an N of one study.
That's a good study, though. That's better than a lot of studies out there.
It's not nothing.
It's not nothing. Yeah. All right, I want you to leave the camera rolling because I know Sam is going to ask us more questions, kind of, but I'm going to say we're done. I want to thank John for taking the time.
Sure, no. Thanks.
I think that was really helpful. You got to spend an hour selling me on A2M, and now I really understand it better. Yeah. As opposed to you have maybe 5 minutes with somebody or 30 seconds. Like how are you gonna? Right. How are you really going to deliver the A2M message?
And what I'll offer up is participate in one of the educational webinars that we have where you'll actually be able to have Q&A with a peer. So a peer physician who has a lot of experience within his practice.
My listeners want to be in those. They want to participate in those webinars. We offer it to my listeners.
Right now, this is set up for physicians. But
will you give out an email?
We'll look at.
Will you give out an email if listeners want to contact you? What's your email?
Yeah, it's John Kippenberger K-I-2-P's ENBERGER at Catalyst, CATALYSTPRN.com.
Great. I appreciate
And
you.
again, that's the website, right? CatalystPRN.com to get more information on
Sure,
on-
yes, you're right.
Yeah.
That's the website, but that's his email. So if you want to message him directly, that would be a great way. You could also message the show, Doc Talk Live. I want to thank you, Sam. Again, you know, this is complicated. There's not an easy answer, and I think that's kind of what you're looking for. Is what's the next step? What's the easy answer? And there is no easy answer. There's no right answer, and so sometimes the less we do, the better job we've done.
Sure, that's an answer in itself. Giving it time to do its own thing. Sure. I would just say, you know, again, from a patient's perspective, it would be wonderful to be able to say, go to your website and maybe this isn't possible, but you could say, this treatment we have, and whatever data you have, even if you say it's very limited, say, this is more effective for this. This is
Sam, I couldn't agree more, and we will get there. We're just not there today.
We're not going to get. Well, we will get there, but it's not going to be. It's going to be years before we're there.
Yeah, it is going to take a little while.
You can see 12 different doctors and get 12 different opinions on the same problem.
You're
absolutely.
Right? I mean,
you couldn't have said it better. Absolutely.
Right. Well, that's.
See how we signed off and we kept talking? This is probably the best part of the whole thing. Was the part that wasn't supposed to get on there. All right, you keep rolling. Don't turn it off.
No. Dr. Yee has enjoyed the conversation.
I think I'm out of questions.
What?
I'm out of questions. Because you're proud of
Thanks,
yourself.
Man. I appreciate it.
Yeah, very good.
Thank
good.
you.
Yeah,
Thank you
I
so
enjoyed
much.
it.
I appreciate
Sam,
it.
great to meet you.
Yeah.
Certainly, best of luck. Hope,
Blake. Yeah, we'll even walk out. Keep it going. Just keep it going.
Follow us down the hall.
Yeah, we're gonna follow you down.
This is the
Is the after?
This is kind of like walking down the studio. We're gonna exit the building.
So Sam, let me what I didn't get a chance to ask you is, so where are you at right now as far as activity level? What I mean, are you not able to play tennis right now?
Oh, I don't know how they even try again. Dr. Goodman thinks that's probably a mistake, but that's a lot of twisting.
Yeah.
That's the part that needs to get on the radio, on the show.
Well, it could right now because
Okay.
what is your saying about exercise?
Oh yeah, that there's good exercise, bad exercise, and no exercise. And bad exercise is better than no exercise.
Or what if bad exercise is what got you injured in the first place?
But maybe it wasn't bad exercise. Maybe it was just living.
Yeah, but you don't
What
know.
if it was life? What if it was coughing, sneezing, pooping, turning over in bed? All these things that you have got to do.
But sure, but no one has a gun to your head and says, if you don't play tennis today, I'm not going to kill you.
But tennis is a good exercise. I mean, tennis is
Oh,
not a
right.
good exercise. Tennis is exercise.
Sure.
So if the choice is tennis or do nothing, then it's tennis. But if the choice is tennis or, let's say, walking on a Nordic track, and you prefer the Nordic track, then by all means do the Nordic track.
You're a pretty boring person then if that's what you're into. But yeah, I'd much rather play tennis. But again, it's when you're trying to find Bin Laden, you kind of don't want to introduce more things that could make it harder to find. And that's
I understand, but when you're trying to live a life, exercise is vital to your health. It's vital.
Yeah.
All right, let's keep going.
All right.
I'll get you all out of here.
So that happened. Yeah. Once your symptoms came back after you said you had your surgery, then stopped to get playing, right?
Oh yeah. No, I didn't play after that. I had an injection with Dr. Goodman, and I think I have had some improvement. So
Sure.
I'll have to see where that.
You guys are probably parked in the front. Go right. Go right.
Right.
Go this way.
Really following us out the door. That's pretty cool.
We're also not giving our viewers a tour of the building.
Yeah, I know. And the exit's just straight that way, guys.
You're also showing them how to break in.
I guess.
We have armed guards here at all times.
All right,
You
guys.
had me there for my, where this goes. So it's not always where you want.
Hey, I want you to put the ping pong video up.
Oh, you think when Clint cheated?
Well, I didn't see that part, but yeah.
Oh.
All right. See you, Sam.
All righty.
All right, can we hit stop? Cool.
finish button.